So now I deliver to Irini that will go through the patient journey.
Thank you. Thank you, Nuno. So what we have just seen by Nuno was the overall teleconsultation journey. And I will now continue with the same journey with the patient and the healthcare professional, but from the perspective of what needs to happen technically in each phase so that the cross-border teleconsultation can work safely and consistently. So the journey begins before any clinical interaction takes place. So the patient requests the teleconsultation, receives the relevant information, and where applicable, it may need national consent or access condition steps before any cross-border retrieval will begin. On the provider side, the appointment is scheduled, the patient is prepared for the next steps, and access to the teleconsultation platform will be enabled. So the key point here is that before the live session starts, transparency, patient information, any national access related checks have to work in a remote workflow, so it's not during the teleconsultation process. So if we go to the second phase, which is the pre-teleconsultation phase, so before the consultation takes place, the healthcare professional in country B authenticates through the usual trust framework and initiates patient identification in a teleconsultation context. So the provider side workflow prepares the request and forwards it through the existing path. The important point is that remote teleconsultation does not need a completely separate matching model. Remote identification may use the appropriate digital identity mechanism, but the result still has to fit into the same established cross-border patient matching process. And having said that, in other words, the remote part changes how identity attributes are obtained, not the safety logic used for patient matching. And if I go to another point of view from country B that forwards the patient identification request, and country A remains the authoritative site for patient matching and identity validation, the same patient safety rules will apply. A unique match is required. So if a member state applies national restriction or access condition checks, those are also handled before any data is released. So even though the route is remote, the process still ends in the same trusted national matching and release logic. So the key message here is that remote teleconsultation still depends on the same authoritative matching process and the same patient safety rules as the baseline for cross-border workflow. And if we go to the third phase, which is the actual teleconsultation, here the patient joins the consultation through the teleconsultation platform, and the healthcare professional in country B uses the previously retrieved cross-border data to support the consultation and record the clinical outcome. The important clarification in this phase is that the cross-border framework does not become the teleconsultation platform. The clinical act remains local in country B, while the cross-border framework supports the surrounding data exchange. So at the same time, the role and responsibilities across healthcare providers, national infrastructures, national contact points, and any teleconsultation platform or service provider needs to be clear. So I'll move to the last phase, which is post-teleconsultation. So after the consultation ends, the journey is still going. So the provider in country B now creates the outcome of the consultation in a structured way. Instead of inventing a completely new teleconsultation report service, the outcome can be represented in a discharge report aligned clinical content and exchanged through the existing hospital discharge report workflow. So the journey shows that teleconsultation is no longer just a conceptual use case. We now have a practical implementation path showing how it can fit into the existing MyHealth EU framework, the before, the during, and the after the consultation. And